On behalf of Cottage Health, I'd like to welcome you to the Pre-Operative Joint Replacement Seminar. My name is Barbara Irvin. I'm an RN, and I work the pre-operative area. This class is meant to prepare you for your successful joint replacement. It is also to help you prepare your home for when you do go home, and also what to expect in the hospital and also after surgery in the recovery room and the floor where you'll be staying after surgery for a night or two. The next two slides explain what is involved in a total hip and then also in a total knee replacement, cemented versus non-cemented, which areas of the bones are replaced. So if you have any questions, your surgeon is probably the best one to contact regarding what type he uses if you've been reading up on the internet and you want a specific type of a prosthesis. The first slide of an x-ray shows two different types of total hip replacements. Your surgeon can answer any questions regarding the type of prosthesis he'll be using. The second x-ray shows a total knee from looking front on, and then another slide, the other half of the slide shows you looking at the side. And as you can see, it's more of a lining and not necessarily like the whole bone being discarded. They just make a new lining around the areas where you've lost your cartilage. So this next slide of optimizing for your successful surgery, just know there are some requirements. Lab work needs to be done usually at least a week ahead of your surgery date, but it can be up to a whole month ahead of your surgery date. Sometimes it's a good idea to have it done ahead of time, and if there's anything that needs to be rechecked, we have plenty of time so that your surgery date stays the same. Ideally, you should be taking this class within 6 weeks of your surgery date. You should have a basal metabolic index that is not higher than 40, and that's based on your height and weight. If you are diabetic, you should have your hemoglobin A1C should be under control, usually 8 or less. If not, maybe it needs to be fine-tuned by your medical doctor. We need you in the best possible health you can be in before surgery. The history and physical, which is usually done by your medical doctor, not your surgeon, will be completed. And if there's anything else, like a sleep study, if you see a pulmonologist, if you see a cardiologist, sometimes they require other studies such as an echocardiogram or a stress test to make sure your heart is in the best possible health it can be in before surgery. Your laboratory testing will usually have a complete blood count, a CBC. We'll have a chemistry panel. We'll also have a bleeding time, which is called a PTT. Also, we do what's called a MRSA, which is for methicillin-resistant staph. That's that superbug we all worry about. And we will be doing a nasal swab, or you will have a nasal swab done by your doctor's office. And these are all done, like I said, at least a week before surgery, and sooner, even earlier if possible. You will need to obtain medical clearance from your primary care physician. If you need any consults, they will be referred out. All dental work needs to be completed at least 4 to 6 weeks before surgery, and that includes teeth cleaning. I know frequently patients know they can't have any dental work for a while after surgery, so they will schedule their teeth cleaning before. So you need to keep that in mind, that you won't be able to have that done right before your surgery. You will need to complete the documents in the front of your joint replacement guide that was given to you by your surgeon, and we will have you bring them to the preoperative appointment with the nurse. Thinking about when you'll be going home, you need to arrange for someone to pick you up at the hospital and to be with you a couple of days at least. It kind of depends on how you're doing. Physical therapy can give you some good ideas about help or people you may be wanting to have help you when you do go home. But for a week or two, you might need help with household chores. You will be tired, you need to rest. You'll be taking pain medicine probably. You may not be able to do all of these things. So it's a good idea to have someone that is able to come and give you a hand if needed. They don't have to be with you day and night, but it's good to have someone that you can call on. Just remember, you're not sick, and we want you to get up and do as many things as possible. If you have a friend there, maybe they can encourage you to go for a walk and help you getting around. You will need to arrange for someone to be driving you to your physical therapy appointments, and you will probably not be able to drive for, depending, but probably a good 6 weeks after the surgery. You need to be off of your pain medicine, and you need to have clearance from your surgeon that you're safe to drive. On the day when you come for your preoperative appointment, you will, first of all, you'll meet with the financial counselor, the admitting clerk, and this is where we ask you to bring insurance cards and a photo ID. If they do not ask for them in the admitting office, then you can put them away and you do not need to bring them to us at all. Usually the surgeon's office have faxed over the insurance cards and photo ID, so we're usually set. If you have an advance directive, a 5 wishes, or a durable power of attorney for healthcare, bring it to the admitting office and they will scan it into the system so it'll be available to all 3 campuses of the Cottage system. If you don't have one, you can get one from the admitting clerk. Just be aware that it needs to be witnessed by either friends, but it shouldn't be family, and also hospital employees are not allowed to witness them. If you routinely take a blood thinner, it will need to be stopped before surgery. Depending on which blood thinner it is, we'll be giving you instructions when you come to your preoperative appointment on when to stop it. During the visit, besides the financial counselor and the nurse, you will probably be meeting with the respiratory therapist and perhaps physical therapy and also the case manager, discharge planner. This next slide shows some suggestions. These are not requirements, but some suggestions about things you can do before you come to the hospital. One is you're going to have people coming to your home, so if you'd like it clean, the time to do it is before you come to the hospital. Think about you are going to be not quite as agile as you've been, so things need to be in a place that it's easy for you to reach, not to be lifting and trying to reach up too high or bending down too low. So think of kind of keeping things at arm's level so that you're able to get to them easily. Also, you want to be safe in your home. You need to pick up any throw rugs, loose carpeting, because you will be using a walker and it will be just easier to get over fewer obstructions in your pathway. The goal of this is to remove any tripping hazards you may have in your home. When you're home alone, if you have a cell phone, have it on you, not next to you. It's a little hard to reach if you get up and go somewhere and you fall. That's the main concern, is you falling. So just have it with you at all times. Consider having a raised toilet seat. It is hard to bend down, particularly the knee patients, to bend down if your toilet is too low. So just to make it easier for you. Also, just remember your towel bars are not grab bars. So a raised toilet seat will give you 2 sturdy armrests to push up and off of the toilet. The Visiting Nurse Association has a loan closet. You can get a walker there. You can get the raised toilet seat. You can get a stool that can go in your shower so that if you're tired when you're showering, you have something to rest and sit on. These devices are all available free from the Visiting Nurse Association through their loan closet. Now, before surgery, it's important to be doing a few exercises because we will be having you do them after surgery. The most important one are the calf pumps, and I always say toes to the nose. And you should be doing these every hour while you're awake after surgery, but you can be practicing them now. Those are to help prevent blood clots, but basically toes to the nose 10 times every hour while you're awake. If you can and you're able to, just a low impact exercise program, it will help in the long run in your post-operative period. And even a slight little weight loss could be advantageous for you in your post-operative time. The bottom of this slide suggests some healthy habits for before surgery that we do want you to continue after surgery. But mainly it's colorful vegetables, protein, this will help you heal, fiber, which is really going to help you in your postoperative period to help prevent constipation. Calcium promotes bone healing, and just know yogurt we're going to kill off all the bad bacteria in your gut with the antibiotics. So by getting some yogurt in, or kefir, or any of these types of milk products, if you can tolerate them, are good to help give you back your healthy bacteria that's normally in the gut. After surgery, your first tray is going to be that delightful clear liquid, Jell-O juice broth. And if you do okay with that, then they're going to hand you a menu, and either you or the nurse or the patient care tech can phone in your order. Something to keep in mind, even if you're not diabetic, trying to stay low on refined sugars is probably a good idea. It just causes your spikes in your blood sugar, you get highs and lows. So if you can kind of try to avoid eating things too sugary, it's a good idea. Just realize your appetite will probably be poor after surgery, so maybe perhaps getting more frequent, smaller amounts would be better than having a big tray in front of you and not really having much of an appetite to eat anything. And then, of course, we want you to try to avoid foods that are high in saturated fats, empty calories. Your appetite will be off after surgery, and you should probably try to get something that is a little more healthy. While you are taking pain medicine, you should not be drinking any alcohol. The day before surgery, try to stay active. Try to stay hydrated. The day of surgery, you will be dehydrated, so getting in plenty of fluids, as long as you don't have a fluid restriction, is a good idea. Also, we suggest a light supper. You may not think you're nervous, but sometimes if you eat late or anything too heavy, you know it's going to sit on your stomach all night long and you'll regret it the next morning. Also, if possible, it's a good idea to have a bowel movement before you come to the hospital. They will be putting you on a stool softener after surgery, but it's good to make sure you're regular before you come into the hospital. The night before surgery, absolutely nothing to eat after midnight. However, the time on how late you may have water in the morning will depend upon what time your surgery is scheduled for. So there may be times when you are able to have a little water in the morning. We will instruct you on which medicines we want you to take in the morning with just a couple of sips of water. The night before surgery, you're going to shower with the shower kit that was given to you in your preoperative appointment, and just know that you're going to use it the night before surgery and again the morning of surgery. You will have a liquid soap along with some washcloths, disposable washcloths that you use, as I said, the night before and the morning of surgery. Read the instructions. Most of them require you to get wet, turn the water off, use the soap, leave it on 2 minutes, and then rinse well. The next slide shows two of our patients who have gotten back to doing what they would like to do. Now, when you come into the hospital the day of surgery, things we would like you to bring: if you wear glasses, contacts, hearing aids, if you have a case for them, please bring them with you. If you need a charger for your cell phone, please bring that. If you filled out your advance directive and have it available, the admitting office can scan it into the system. And any personal care items, toothbrush, toothpaste, we do have those products here, but if there's something you use particularly, then bring it with you. And a pair of comfortable non-skid shoes or slippers, but they should have a back on them so that you're sure-footed when up and walking with the nursing and physical therapy. If you use a CPAP machine, bring it, please. It will be checked by the engineering department to make sure that the electrical cord is good and is safe. Usually we do not have you bring any medications except eye drops and inhalers. So bring them. We will put labels on them and have them available for you later. You do not need to bring any jewelry, any cash. Leave those things at home. Now in the morning, you can brush your teeth. We just ask you not to swallow any of the water. We also ask you not to wear any lotions or makeup. Parking at Goleta Valley Hospital is close to the front of the hospital, and at Santa Barbara Cottage Hospital, they have valet parking, and you also could use the parking structure that's located on Castillo and Bath Street. When you come into the hospital the day of surgery, we ask you to limit your family members to just 1 or 2 at the time. Our bays are small, and we have a lot of information that we'll be going over with you, having you sign a consent for surgery, a consent for a possible blood transfusion. If you are having a knee or a shoulder replacement, the anesthesiologist will be discussing with you, and we will ask you to sign a consent for a possible nerve block. So these are all things that will be done before you go into the operating room. In the hospital, the nurses will be listening to your heart, your lungs, we'll get your vital signs, we'll start an intravenous, and everyone's going to be asking you, what are we doing, what side, who's your surgeon, what's your birth date, and we're all just double, triple checking that everything is as it should be. Your surgeon will come in, he or she will mark the arm, the leg, the shoulder, whatever we're doing with their initials, and you will have an opportunity at that time for any last-minute questions to speak with him or her. Also, kind of think of who you want the doctor to call when the surgery is over if no one will be waiting. The anesthesiologist will be in. He or she will listen to your heart and lungs. They'll be talking to you about the anesthetic for this surgery and also what their plans are for pain management for you for after surgery. The nurse that will be circulating in the room will be in to talk with you, ask you, of course, what side we're doing, what's your name, what's your birth date again. Now, when you go off to surgery, your family can either wait in the waiting room. I suggest, though, they go home or go do something. There's really not a lot they're going to be able to do here, but they're more than welcome to stay. But if we get a phone number, then the surgeon will call, tell them how you did, and then just know that from that call, you'll be in the recovery room anywhere from an hour and a half to 2.5 hours before they'd be able to come back and see you up in your patient room. When you're in the recovery room, it's also called the PACU, which is post-anesthesia care unit. No visitors are allowed there, and that's the time when the surgeon would be calling the family. When you're in the recovery room, there's a lot of bells and whistles. They have a lot of monitors that go off. Usually the most common one is the one that's telling you you need to take a deep breath, and they'll be reminding you too. You will have oxygen. At first, probably maybe a mask, sometimes just the little prongs that fit in your nose. And usually you will have oxygen for about 4 hours after surgery till you're more awake and able to deep breathe and not have those alarms go off that you're not breathing deep enough. In the recovery room, they frequently take x-rays, so just know that is another thing that will be going on in that room. If you're having any pain, let the nurses know. They're there to help you, and they will, at first, they'll be giving you medicine through the intravenous.
Hi, my name is Melissa Ortiz, and I am a registered nurse on the medical surgical floor at Cottage Health. I am going to be going over what to expect while you're in the hospital and during the early recovery period. So once you are ready to be discharged from the post-anesthesia care unit, you will be transferred to the medical surgical floor or the orthopedic floor. You will be staying there for about 1 to 3 days. Usually the knee replacements tend to stay a little longer than the hip replacements. You will be cared for by a joint replacement team, which consists of your surgeon, a registered nurse, a patient care technician, or you may hear us call them PCTs, a physical therapist, an occupational therapist, if your surgeon orders that for you, respiratory therapist, a case manager or discharge planner who will be working behind the scenes to get things ready for you once you're ready to go home. Dietitian and spiritual care are available at both of our hospitals as well. If you would like to speak to a dietitian or someone from spiritual care, just let your nurse know and we can arrange that for you. So painting a post-operative picture. Initially, we're going to be in your room often. We will be taking your vital signs every hour for the first 4 to 6 hours after surgery. We are going to be monitoring you very closely. You are going to have oxygen through a nasal cannula. You will have an IV access, an intravenous access, which we will be giving you IV fluids, antibiotics, and possibly pain medication initially. You may have a bladder catheter to drain your urine. We call them Foley catheters as well. If you have a Foley catheter, that will be placed during surgery while you are asleep or numb. The Foley catheter does come out the first morning after surgery. You will be wearing compression stockings or TED hose if the surgeon orders that for you. We like you to wear those for most of the day for the first 2 weeks. It is okay to take them off to wash them or to shower, to bathe. You will also be wearing pneumatic compression devices, which are wraps. They wrap around your leg and they are to help promote circulation. They pump up intermittently. In the first 1 to 2 hours after surgery, a respiratory therapist is going to come to your room and show you or remind you how to use the incentive spirometer, also known as the Voldyne. This is to help keep your lungs strong and help prevent pneumonia. Your incision will have stitches or surgical glue covered with steri strips and or maybe a bandage. The knee replacements, the dressing tends to be bulkier. We put a couple ACE wraps around it for the first couple days. The staff should be bringing you ice, either physical therapy or nursing, or the patient care tech will be bringing ice packs. We like you to use them about every 4 hours to help with pain management and to help decrease swelling. Blood draws. Very early in the morning, the first morning after surgery, lab is going to come in and draw your blood. They need to get this done early so that the doctors have the results back early in the morning. They like to look at your lab results before they start their day. They want to make sure your electrolytes are in balance and see if you're showing any signs of infection. Bathing and showering. Your surgeon may order for you to shower before you go home. If not, the staff will help you to clean up in the bathroom or sponge bathe. And we will go over on discharge when you can shower. Most people are able to shower within 72 hours after the surgery. Bowel function. Bowel function is very important. Surgery itself, anesthesia, pain medications, immobility, all of these things are constipating. So we want to make sure that we avoid that. In the hospital, you will be on a bowel program. That's where we give you stool softeners every evening and every morning. But this is something you need to continue once you go home. So make sure if you have something that works for you, that helps prevent constipation, make sure you have that on hand for home. Visiting hours, we don't have visiting hours anymore. Your family is able to come whenever they'd like. However, there is quiet time after 8 o'clock. And if you have friends or neighbors that want to come visit, the best time for them to visit is in the afternoon. The mornings are very busy and we want to make sure you get your time with physical therapy. Pain medication. Unfortunately, you will not be pain-free. However, we do want you comfortable enough to do physical therapy and be able to drift off to sleep. Everyone is going to ask you to rate your pain from 0 to 10. Initially, you will be given pain medication through your IV if needed, but this option is usually stopped first thing the following morning after surgery, if not sooner. Our goal is to get you transitioned to oral pain medication as soon as possible, as soon as you're able to tolerate them, so we can make sure the medications are going to work for you at home. We use a multimodal approach. Multimodal just means using 2 or more analgesic agents with different kinds of action. When used together, they have a synergistic effect and they allow for better pain relief. They also tend to allow for less use of opioids. Examples of different types of medication we would use are Tylenol IV, Celebrex, which is an anti-inflammatory, possibly Lyrica or something similar for nerve pain. We use regional anesthesia or local anesthetic. Peripheral nerve blocks are used for the knee replacements only. Unfortunately, for the hips, there's not a nerve they can use to block the pain. However, the hip replacements tend to have less pain. We also give routine pain medication around the clock. This is usually tramadol. We'll give it about every 6 hours to provide some baseline pain relief. IV pain medications are given by the nurse if you're not able to tolerate oral medication for the first several hours after surgery. Common IV medications are Dilaudid, morphine, or Toradol. Once you are tolerating food and fluids, we're going to transition you to pills by mouth. And common oral pain medications are Norco or hydrocodone, Percocet, or oxycodone. Make sure to try and take your pills with food so you don't get an upset stomach. The best thing to take your pain pills with is a high fiber bread. If your pain is not controlled by the pain medications ordered for you, make sure to let your nurse know so they can contact the surgeon and discuss other pain options. Don't wait. Please let us know as soon as you're having pain or your pain is increasing. Do know that the oral pain pills take about 45 minutes before they start working, so please don't wait to let us know. And we try and coordinate your pain medication with physical therapy so that you're taking your pain pills about an hour before physical therapy comes to your room.
Hi, my name is Amy Hicks, and I'm a physical therapist here at Cottage Health. And I'll be talking to you today about what to expect from physical and occupational therapy during your post-operative period. As far as physical therapy goes, physical therapy will be working with you twice a day. They will be doing range of motion and strengthening exercises, working on your bed mobility, working on transfers and proper gait, and doing stair training as needed. Occupational therapy will work with you once a day. They will work with you on dressing, bathroom activities, including the toilet, shower, and tub, grooming, and how to do safe car transfers. Some of the keys to rapid recovery following your surgery. You will be assisted to walk and get out of bed several hours after you arrive in your room the day of surgery. Expect to get out of bed early and often. Dress for success. You are not sick. If you get dressed, you will feel better and be more motivated to move. Be proactive. Sit up in a chair for meals. You don't eat in bed at home. Use pain medication prior to therapy and ice after therapy. Keep moving. We want you to walk, walk, walk over the next several months. I'm now going to go over some of the precautions that you might have after your surgery. As far as hip precautions go after surgery, if you have had a posterolateral approach, these are the things that you should avoid. Avoid crossing your legs, avoid turning your leg in, and avoid raising your knee higher than your hip, which you can see in the attached photo. If you've had an anterior approach, avoid pushing your leg backward at the hip and avoid turning your leg out. You want to practice these precautions until cleared by your surgeon, usually 6 to 8 weeks. Please ask your surgeon about this at your follow-up appointment. In the posterolateral approach, again, no crossing the legs, sitting where your knees are above your hip, or letting your foot fall inward while in bed, or leaning forward to get out of a chair. If you've had the anterior approach, don't take too big of a step with your surgical leg behind or letting your foot fall outward while lying in bed. These are the knee precautions following a total knee replacement. You have no positioning precautions. Never put a pillow behind your knee, only under your calf or your heel to keep your leg straight. Work at keeping the knee straight so that you can normalize your walking. Ice and elevate after exercising and before bed to help control pain and swelling. Do not jar your knee. Try to do frequent position changes to keep the knee from getting too stiff. Remember to keep the legs straight when in bed. Knee bending or flexion comes with knee extension or straightening. Demonstrate trying to walk with your knee bent to emphasize importance of extension to walking ability. Ice several times a day for 20 to 30 minutes at a time, and never put the ice directly on your skin.
Potential complications after surgery. Blood clots are a potential complication after orthopedic surgery. Signs and symptoms of a blood clot are pain or tenderness, warmth and or redness in your calf. Another sign is swelling, localized to the calf area only. If you elevate your leg and the swelling does not decrease, then we may be worried you'd have a blood clot. Chest pain and our shortness of breath are more of a medical emergency. That would be if a blood clot from your leg has dislodged and moved to your lung or heart. If you are at home, you would need to call 911 for this. Any other signs, as mentioned earlier, the pain, tenderness, swelling in the leg, you would want to call your surgeon. Prevention. To help prevent blood clots, you're going to be on a blood thinner for 2 to 4 weeks after surgery. Most of the surgeons prescribe aspirin, 81 milligrams or 325 milligrams twice a day. It's a good idea to take the aspirin with food because aspirin can be hard on the stomach lining. If you have a history of blood clots or a cardiac history, your surgeon may prescribe a different blood thinner for you. It's also important to remember while you are taking a blood thinner for the 2 to 4 weeks to avoid NSAIDs, anti-inflammatories like ibuprofen, Advil, Aleve, while you're taking the aspirin because they can also increase bleeding time. It's very critical that you take your blood thinner as directed by your doctor for as long as prescribed. The other things you can do to help prevent blood clots are staying active, walking, doing calf pumps, and wearing your pneumatic stockings while in the hospital and your white TED hose once you go home. Some more potential complications after surgery are infection. Signs and symptoms of infection are a persistent fever greater than 101 degrees. We say this because it is common to have a low-grade temperature after surgery. If you have a low-grade fever, 99 to 100, make sure to do some deep breathing, walk around, drink some water, and recheck your temperature. It probably went down to normal. But if you have a fever above 101 degrees, you do need to call the surgeon. Another sign of infection is increasing redness and or drainage from the incision. A little bit of clear fluid or bloody fluid is okay, but any other color is not okay and you want to call the surgeon. To help prevent infection, the best thing you can do is practice good hand washing and make sure you're eating a healthy diet. That will help prevent infection. You will also be on intravenous antibiotics for 24 hours after surgery to help prevent infection. You also want to keep the site clean and dry. Pneumonia is another complication after surgery. We tend not to deep breathe when we are in pain, so you need to consciously work on keeping your lungs strong. You can do this by coughing and deep breathing. We want you to use your incentive spirometer as shown to you by respiratory therapy 10 times every hour while you're awake in the hospital, and we will send the incentive spirometer home with you as well. We want you to continue to use it about 4 times a day for the first couple weeks. After that, please throw it away. Moisture does build up in the incentive spirometer, and then bacteria will grow in there. Dislocation is very rare. To help prevent dislocation, you want to practice the precautions as shown to you by physical therapy, specific to your surgery. It's usually 6 to 8 weeks, but you want to practice those precautions until your surgeon has cleared you. So transitioning to home. The goal is to get everyone home. Studies show patients have better outcomes when they go home. It's a good idea to make arrangements to have somebody stay with you for the first 1 to 2 weeks. You will be able to get up and walk around, but initially you may need some assistance with showering, helping prepare meals, helping bring you ice packs, things like that. If you absolutely don't have anyone who can help you, you may need to go to a skilled nursing facility or a rehab, if qualified, for a few days. Take note, Medicare does require a 3-night qualifying stay before you can be sent to a skilled nursing facility or a rehab. Outpatient physical therapy usually starts about 2 weeks after your surgery if you need it. For the first 2 weeks, the discharge planner or case manager will set up in-home physical therapy for you. Living with your new joint. Keep moving. A moving joint is a happy joint. Don't sit in one spot for longer than 30 to 45 minutes. Get up, go to the bathroom, walk around a little bit. Just don't stay in one spot for too long. Remember to follow any precautions for your surgery. Keep your follow-up appointments. Most surgeons like to see you about 2 weeks after the surgery. Don't drive until cleared by your surgeon. And of course, you cannot drive while taking narcotics. Activity, you can get back to almost anything except constant running. Antibiotics, do remember you may need to take antibiotics before any dental work. So check with your surgeon and your dentist about this. Sexual activity, the surgeons do want you to wait 6 weeks to resume any sexual activity, keeping your precautions in mind. If you have any questions or concerns that weren't addressed in this presentation, please refer to your patient guide or the orthopedic page on cottagehealth.org, or reach out to your surgeon or to the facility where you are having your procedure at. We hope you found this presentation helpful, and we look forward to taking care of you.